Hi, I'm Dr. Michael Morris, and with Lone Star Surgical, I'd like to welcome you to the preoperative course in bariatric surgery. This is information that I think every patient considering bariatric surgery should know and understand well prior to undergoing a surgical procedure. First thing I would like to address is the question that no one asked me. What would I do if I found something else in the abdomen prior to the surgery? The answer is it depends on what I find. If something is more important than the bariatric surgery to be performed, the surgery cannot and should not be performed. So therefore, an exploration is the first thing I do with all patients at the beginning of the procedure. That exploration continues with the stomach. As seen in this slide, the gallbladder, the spleen, the liver are in the view of the surgical procedure while it's being performed. If a gallbladder appears bad with adhesions, then that's something I would address at the time of the surgery, oftentimes knowing that before with an ultrasound. Now, specifically speaking of a gastric bypass, the big complication of leakage is a tension-related phenomenon. Therefore, at the upper anastomosis, reducing the amount of tension is paramount in preventing the complication of a leak, as with its blood supply. Therefore, during a gastric bypass, I perform that behind the stomach and behind the colon to reduce the travel of the small intestine in getting up to a small gastric pouch. That essentially functions by reducing the acid exposed to the small bowel, thereby preventing or reducing the chance of marginal ulcerations of the small bowel and maximizing its blood supply by reducing the tension required to travel that distance. This is the view illustrating the anatomy of the stomach and the small bowel. They're two separate organs. The stomach is thick with a thick muscle layer so that food can be ground to a paste prior to be delivering to the small bowel. Now the small bowel is very thin, designed for absorption. When you connect the two, as in a gastrojejunectomy during a gastric bypass, reducing the stomach acid-producing tissue is very important. That illustrates the importance of performing a very small gastric pouch, not only for outcomes, but to reduce potential complications discussed previously. Now, I also put this slide up to illustrate the importance of smoking cessation. It is very important, essential, to stop smoking prior to the procedure, not only to reduce the damage caused to the lungs and the arteries, but to reduce the complications related to a gastric bypass in the form of ulcers or bleeding. Simply put, 100% of people smoking that have a gastric bypass will develop ulcers, and those ulcers are ultimately preventable by stopping smoking. Now, we move to a sleeve gastrectomy. This procedure is performed only on the stomach, not involving the small bowel. It is the longest staple line performed in general surgery at nearly 35 to 40 centimeters in length. It appears to be a very easily to perform surgery, but it's very important for the function of the stomach to make a small conduit. The smaller the sleeve, the more effective the sleeve. However, the smaller the sleeve, the more reflux and the higher the leak rates are with the sleeve. And I oversew that staple line to reduce the complication of a leakage. A sleeve gastrectomy leakage is a very difficult problem to deal with. It is a high-pressure conduit that oftentimes requires multiple interventions to resolve in the form of stenting and/or reoperation or conversion to a gastric bypass. I personally believe most leaks of a sleeve can ultimately be prevented. This is why I oversew and I pexy the adipose tissue on the inside to the staple line to better balance the forces on the sleeve to prevent obstructions or kinking of the sleeve. Reflux. This is the largest problem associated with a sleeve gastrectomy and the most common reason for conversional operation of a sleeve to a gastric bypass. I believe those with reflux will ultimately have reflux after a sleeve gastrectomy. Those without reflux prior to a sleeve may develop reflux requiring further interventions. And this is because the pressure below the esophagus created within a sleeve is higher than the pressure of the sphincter between the esophagus and the stomach. Going back to a gastric bypass, the internal hernia is only associated with a gastric bypass. Anytime that small bowel is divided and reconstructed, potential spaces exist that could represent a risk for developing an internal hernia. That's something that would require surgical intervention to resolve. Knowing your history is essential after bariatric procedures. Stating that you are a gastric bypass patient with abdominal pain should orient most providers to an internal hernia possibility. This is something that is easily remediable with a surgical intervention, although major complications if not identified. That's the importance of following up with your local bariatric surgeon that knows you well in preventing and dealing with these potential complications. The leak. The leak in a gastric bypass and a sleeve gastrectomy present very similar. Most patients will develop abdominal pain. Most patients will develop fever. Most patients will develop tachycardia or an elevated heart rate. A sleeve gastrectomy under high pressure is a leak that's very difficult to control as compared to a gastric bypass, both of which will often require intervention, whether through endoscopy or surgical intervention to resolve these issues. I stated before, leaks can be prevented by performing this surgery safely. However, 1% leak rate does exist with both procedures. Leaks, although present a major problem, should not compromise the patient. Early intervention is paramount in controlling and identifying a patient that may have a leak. Reoperations, oftentimes with laparoscopy, can control the problem of leakage. Anyone can develop dumping syndrome. A gastric bypass would require smaller volumes to cause dumping syndrome. Dumping syndrome is a metabolic consequence of increased sugar intake through liquids oftentimes directly into the small bowel, as in a gastric bypass anatomy. The sugars are immediately absorbed in the small bowel, raising the blood sugar, followed swiftly by insulin surge, which is very effective in clearing the blood sugar, although insulin lasting longer causes hypoglycemia. Hypoglycemia often causes the symptoms of dumping syndrome: fainting, weakness, abdominal cramps, and even passing out. It is preventable oftentimes by preventing the substances that are associated with that in liquid calories. These are things that you shouldn't be doing anyway after bariatric procedures. Pulmonary embolism and DVTs are not common entities associated with surgery, but they do occur. The risk factors for these entities include age, gender, medical problems, and surgery. Laparoscopic surgery will have a higher incidence of pulmonary embolisms and deep venous thrombosis secondary to the increased pressure of the abdominal cavity. What I do to help prevent these entities are to shorten your surgical experience. I'm a part of the team that prepares you for anesthesia. I help intubation. I help prepare you and position you on the table and initiate the incision as soon as possible. I do a surgery that's optimized based on you to finish the surgery in a timely manner in efforts of reducing your anesthesia time. This, with you walking around within a few hours of surgery, can effectively prevent deep venous thrombosis. Everyone that gets surgery will have complaints of postoperative pain. Again, reducing the surgical times can help prevent and reduce postoperative pain. I give local blocks and regional blocks at the time of surgery to reduce the pain associated with surgery. So the information I listed above is a list related to bariatric-related issues postoperatively. The most important is to contact your surgeon immediately with questions. If you think you have a complication related to bariatrics, having a local surgeon is paramount. A surgeon that you can call and that will respond to you. I'm Dr. Michael Morris with Lone Star Surgical. I'm available to you for any of your bariatric needs. It has been a pleasure speaking with you related to bariatric issues in the postoperative period. Thank you.